immediately you introduce kind of like some qualifications, some wishy-washiness into this idea that the right is a right to the highest attainable standard of physical and mental health. And this is something that continues to kind of plague discussions about the right to health. And so there are various aspects of the instrument that recognize core obligations that must be satisfied even in a limited resource context. But then a lot of the content of what the right to health entails is understood to be subject to something called progressive realization. So I've used this term already, the idea of realizing rights to health. What that really means is fulfilling your obligations as a duty bearer under the right to health. And progressive realization means we're making progress in light of what is the highest attainable standard, in light of resource constraints, in light of other priorities that we might have. So this raises another sort of complication when we start talking about positive rights and rights to sort of economic, social, and cultural rights, as opposed to negative rights to be left alone. It immediately also raises this question of priorities, that a country may, for example, decide that housing has a bigger effect on health outcomes than healthcare does. And so recognizing a right to health does not help you necessarily resolve that conflict, although others would say that it does, because it suggests that the metric that should be used is health, and whether it may be that housing is actually a more effective way to promote health at the aggregate level than more healthcare in any given setting, right? All right. So the next component that I want to introduce is the idea that the right to health is not phrased as a right to healthcare. It is phrased as an outcome, not as a good or service that you have a right to, but it is understood to encompass rights to healthcare, but always in service of health. So the goal is health promotion and health protection, not a right to healthcare for its own sake, which is worth keeping in mind in terms of that prioritization question about like the social determinants of health versus healthcare. That runs into some difficulty though, because the framework, this is now the AAAQ framework that I have at the bottom of the slide here, was clearly written with healthcare in mind. And so then they sort of phrase some of it to say, yeah, but also other health-related services, we mean for this to apply to that as well. But it most intuitively applies to healthcare. So I just want to say at the outset, I'm about to talk about things that sound like they really only relate to healthcare access, but the right is meant to encompass the social determinants of health as well. So just like some countries recognize a right to life and the right to health is understood to be incorporated into that, some countries recognize a right to health, but not a right, for example, to water or food, and water and food are understood to be incorporated into that right to health. So the metrics for progressive realization of the right to health include availability, accessibility, acceptability, and quality. So I'm going to say a little bit about each of these, because I think this is now the first framework I'm introducing that can help you identify, sort of like problem-solving exercise to identify how do I want to structure this argument that I'm making on behalf of a population that's facing a health risk. Availability. So in the US, we tend to think about healthcare access, right? We tend to immediately jump to affordability. But I think the current state of the policy landscape with respect to particularly reproductive and sexual health services really drives home that availability is a precursor to accessibility. Something can be affordable, and we can think about whether it's affordable or not, but if it's not available, if the service doesn't exist, then that's even more of a constraint on access. So availability is the existence of those services. Are the services sufficient in terms of quantity and type? Availability can be affected by regulatory barriers and criminalization. So a government can impede the right to health, can fail to respect the right to health by prohibiting certain services. And again, those could be healthcare services like abortion, or they can be health information services, like prohibiting sharing of information about safer sexual practices, for example, if it's in the context of a statement, a message that recognizes the dignity of sex workers, right? So availability can be criminalized, it can be prohibited outright, but it can also be limited, constrained by regulatory barriers. So an example that might be more intuitive now after the pandemic would be a lot of like public health emergency declarations are really about identifying regulatory barriers and removing them. So for example, streamlining regulations around payment for telemedicine services. So unwarranted, undue regulatory burdens can burden availability, can reduce availability of a service, even though some regulatory burdens might be justified, might be appropriate. It's important to keep in mind that trade-off of regulatory burdens potentially limiting availability of services. The other one, the other kind of regulatory barrier that comes up a lot in healthcare law is something like scope of practice limitations. So if you are defining a certain service as the practice of medicine, and then saying anyone else who performs that service who doesn't meet certain qualifications is violating the law, that also affects availability of services, and it affects the type of services that are available. So an example might be midwifery, for example, and whether that is defined as within the scope of practice of a physician and therefore prohibited for someone to engage in if they're not either a physician or supervised adequately by a physician. And all of this is to say not that means availability always takes precedence over other considerations like safety, but only that we should be cognizant of this dimension, right? We should always be thinking about these criteria to help us understand trade-offs in some situations. Accessibility receives the most attention, and financial accessibility is the one that probably comes most readily to mind in the US context in particular, where our prices for healthcare services are so exorbitantly high. But it also includes other dimensions that are worth noting. So physical accessibility, which includes physical accessibility for people with disabilities, but also things like distance, geographic accessibility to where is the nearest hospital that is offering various levels of care and service. Is the route safe to travel is another consideration there. Financial accessibility in the international context, we tend to use the term user fees, right? Here we might call that copays or just prices or coinsurance or whatever else. But remember, this doesn't just apply to healthcare services. Are user fees reasonable given the economic means of those who need access to the service? So the international human rights community, for the most part, in official documents, has not taken the position that user fees are prohibited, but rather that they have to bear a reasonable relationship and that there has to be some kind of means basis to the fees that are charged. Are there other indirect costs associated with the service? So thinking about transport, time off work, other kind of financial barriers to accessing healthcare or other health-related service. Administrative accessibility. This is one that I love and that I think physicians, it really resonates with you because you see the bureaucracy that is involved in healthcare for yourselves as providers, but also for patients. Is a particular kind of registration required? Does accessing relevant information require a bank account, a credit card, an internet access, a mobile phone? What level of literacy is needed? Are the facilities open at times that are convenient? Social accessibility is one that I spend a lot of time working on in my work because I do a lot of work on health and stigma. And so this is sort of attention not just to the financial costs of healthcare, but to the social costs of accessing healthcare. Not just whether providers are respecting non-discrimination requirements in the provision of services, but also are there risks of stigma or discrimination associated with, say, being seen in a facility or being seen to be a user of a health-related service. Information accessibility, whether the information about the services is accessible to those who need it. Language accessibility, but also formats and modalities, making sure that your message, the information about the service is available and navigable by the population. Acceptability. This is one that gets primarily into kind of cultural sensitivity, but also into other ethical considerations that might come into play. So are services respectful of the culture of individuals and communities? Does the administration and modality of services take cultural considerations into account? But also more broadly, do services comport with ethical and professional standards? Do service providers respect confidentiality and informed consent, right? Because that may or may not affect the quality of healthcare services, but it affects their acceptability to the population. This also relates to that social cost aspect with respect to access. Are services sex, gender, and age sensitive? Just sort of calling out those considerations specifically. Are there certain characteristics of the service providers, and this one gets, somewhat more controversial, such as their sex, gender, and their status as international versus local staff, for example, that make the community more or less comfortable accessing the services. So this is the acceptability of the services to the community, but taking the onus off the community, taking the onus off of like, don't they know this is available? Why aren't they accessing it? Don't they know it's important? And instead examining the way the service is provided to decide whether it is acceptable to the community, putting the onus on the service provider rather than the community. And then finally, quality, which we all sort of intuitively have a sense for. Is there, do the providers have the necessary skills and training? Have there been investments made into that? Are there adequate supplies, drugs, services, devices that meet relevant standards? Are facilities safe and sanitary? Are services provided an acceptable standard of care in alignment with relevant standards, right, is sort of the overview here. But also, I think, a recognition that dignity, being treated with dignity before, during, and after accessing the service is a component of quality of that service. All right, so that's my first framework. I'm going to pause there and ask any questions about that framework, because I'm going to introduce some others, and I don't want you to forget it later. Are you finding this helpful in thinking about how you would kind of articulate arguments on about the things that you care about? All right, if questions come up, you're not used to people asking about questions midway through, maybe. All right, a passive moment. That's okay. We'll come back. With my law students, it's like the moment I invite questions, hands. They have helium hands. All right, so now I'm going to go into a reminder about the power and limits of human rights for health advocacy, right? And I'm making certain baseline assumptions about my audience that you see yourselves not just as physicians or clinicians, but also as advocates for health. The structural power, as I said, of human rights is limited. And I think it's important to say that at the outset. Otherwise, I think it can come across to some audiences as naive to say, like, but we have these rights. And you know from your experience of the world that those rights are not always justiciable, that the enforcement mechanisms are lacking, that they might not even be sort of like realistic to conceive of a binding mechanism that would apply. And that might not even be desirable in some instances. But again, I want to highlight, particularly with respect to kind of the legalistic understanding of human rights, it applies to the obligations of state actors with respect to people within their borders. So that, I think, is always a limitation of the kind of legalistic sense. And there are various scholars and advocates who have tried to push back against that and articulate potentially binding frameworks that are cross-border. And that can happen in other instruments. So for example, and I'll come to this example a little later as well, for example, the World Health Assembly can adopt regulations that are binding on states to engage in benefit sharing in response to sample or information sharing. So for example, if one state shares viral samples with the international community, with the World Health Organization, and then those samples are used to produce vaccines or treatments, there can be a legal mechanism to ensure that the country that shared that information has a legally enforceable right to share in the benefits, right? To not have patent protection, for example, apply to the benefits that arose out of material or information that they shared. So that can come into play, that cross-border obligation, but that's not coming out of the human rights instrument directly. It's got to come out of more like a legislative process. And in spite of those limitations, I want to repeat that as rhetorical frameworks, human rights offer powerful tools for generating persuasive arguments, not just in like, and when I say rhetoric, I don't mean like that's not meaningful or that's mushy or it's soft, like not just in the sense of like writing catchy slogans, but in the sense of a rigorous, systematic way of identifying who needs to do something and what they need to do, who has power to do that thing, who should have power to do that thing, and then translate all of that into legally enforceable mechanisms. All right, so I now want to introduce a new set of typologies, negative rights versus positive rights, which is one most of you have probably come across at some point in some kind of context. But then separately, this typology of obligations of duty bearers to respect, protect, and fulfill health-related rights. And those two things are related. So I start with the one that people are kind of more familiar with. So negative rights just means rights to be left alone, by government, right? And if you're, if you've grown up in a US context, or even if you've just been here long enough to be in school, you're familiar with that. This is what Americans mean when we talk about rights, right? We talk about like freedom, liberty, rights to have government stay out of our lives. That is what is most firmly recognized in the US federal constitution and in state constitutions as well, although some of them have been revised or written more recently than the federal constitution has, and they do recognize positive rights, as I said, particularly with respect to education. That relationship between negative rights and health is more complex than it's often portrayed to be. So in public health, like if you take a class on public health law or policy, you're going to hear a lot about like the whole focus of this is about individual rights versus collective needs, and they are in conflict with each other. And I want to acknowledge that is often the case. So Governor Newsom wants to say church services cannot operate in person as a community mitigation strategy for the pandemic. And the churches sue, and the Supreme Court says Governor Newsom cannot do that because of the First Amendment protection of the right to freedom of religion, free exercise of religion. That is a classic story, right, of individual rights in conflict with collective needs. In the US, we are a highly individualistic society, and we have exported that individualism to many of the countries whose policies we've influenced through our economic and financial policies. That said, there is this other story. And again, I think this is something that is coming to the fore more in the current context around sexual and reproductive health, which is protection for individual rights can further health. It can advance and promote health to protect individual rights. So one example, for example, to throw out there would be freedom of speech has actually been invoked by public health organizations working in the global health space to protect them from a government mandate that they have to adopt an anti-prostitution pledge, is what it was described as in a federal law that applied to any organization that was receiving federal funding, including federal funding to address, needs surrounding HIV, AIDS, hepatitis, and other things where messaging from those service providers that respects the dignity of sex workers could actually be quite crucial to working with that audience, to reaching that audience and meeting their needs in a health promoting way. And so they sued and successfully were able to gain a Supreme Court decision saying that their First Amendment rights to not speak, to not take that anti-prostitution pledge were violated by that condition on federal spending. But on the other hand, there are still these limits, and they apply even beyond kind of the individual rights. So one of the challenges with individual rights versus collective needs is that corporations are getting very savvy about asserting that they are rights bearers. An example that comes to mind is freedom of speech for tobacco companies has been invoked to block advertising restrictions, to block requirements to put, say, graphic warning labels depicting the health harms associated with tobacco use on their products. So now switching back to the idea that, this relationship is complex, and it often is the case that there is tension, direct conflict between protections for, particularly for negative rights and government. This idea is the idea of rights as trumps, and that idea came about before the Trump administration, but now takes on different resonance. But it's an idea in legal theory that what rights do, first and foremost, is they are limits on what government can do. Right? Rights as limits, rights as trumps, that they mark off what you might think of as counter-majoritarian limits on what the majority can choose to do in a democracy, right? So if we think of government and law as what we do collectively, like a mechanism by which we set rules for our collective life together, rights carve out certain limits on what the majority can decide, right? But again, and that idea is really important. It has lots of resonance and can promote health in many ways. But when it is then also invoked in health harming ways, invoked particularly by commercial interests, we start to see, some of the complexity there. Another example is freedom from discrimination. And the way that discrimination is interpreted has huge importance. And this is an area where the US Supreme Court has been very active with a key decision that I'm sure you're all aware of last year about civil rights protections in college admissions. You may not be aware that that decision has implications far beyond higher education. That decision is actually now being invoked. For example, actually just yesterday, I think there was a news story about a program aimed at preventing Black maternal mortality, which they've now, the sponsors of that program have now been sued for racial discrimination because the program targets Black women for beneficial provision of services, right? In another example, New York State adopted race and ethnicity as one among other criteria for thinking about allocation of scarce COVID treatments at a time when therapeutics were scarce. They said, what we're seeing on the ground in this state is that race and ethnicity of the patient matters to severity of disease and to outcomes, and that should be part of the clinical guidelines. And we own, right? The government owns the scarce supply right now. And so we get to attach sort of like, here are the guidelines that you should use. If we give this to you to distribute, here are the guidelines, right? That you need to use in deciding which patients receive this scarce resource at the time when it was very scarce. And government, opponents sued. The Supreme Court ultimately did not take that case. It was just before the college admissions case. But two justices wrote separately to dissent and to say the court should have taken this because this is a clear violation of the equal protection clause in the Constitution. So there are different interpretations of what an anti-discrimination rule means. If freedom from discrimination is interpreted in what's called an anti-subordinationist way, is interpreted as a prohibition on systematic subordination of one group to another, then the prohibition on discrimination can empower government agencies and private litigants to dismantle racial or ethnic segregation in hospitals, for example, as happened in the US and in many other places, nursing homes, or even or housing, or health or other settings. But a formal equality interpretation, which is what the majority of the Supreme Court has now adopted, of prohibitions on discrimination, can prohibit government agencies from relying even, now this is like the next step that people are interested in, what about something like a social disadvantage index? Is that something you've come across? So these are indices that are used to allocate scarce resources, or even to just engage in planning for something like a natural disaster. And they, many of them go at the level of like a census tract here in the US, but it can go, at different levels, geographic scales, depending on the country setting that you're working in. But it does include racial and ethnic makeup as one among several factors. It also includes, average household income. It includes, whether it's rural, sort of availability of different services, but one of the factors is demographic, race and ethnicity. There's now a real question. Some of the work that I'm doing with a nonprofit organization is trying to advocate sort of, let's not do the Supreme Court majority's work for it yet, right? They haven't said this yet, but there can be a chilling effect of a decision that says, that causes government leaders to say, well, the social disadvantage index takes race and ethnicity into account. We are no longer going to allocate resources even based on that. Or we need a new index that ignores, just is completely blind to race and ethnicity. So another sort of example of kind of push-pull. Yeah.
So I think I want to put a picture on is that like saying the highest quality that we can offer in people, because say I live in a place where the medical like infrastructure is really like stressed, and maybe like I need a resource that's just not, I just can't get.
It's just not currently available. Yeah.
On my life versus like if I live somewhere that has it.
I think that's a good example of the negative positive dichotomy that I'm talking about. So if you're in a context that only recognizes negative rights claims, then you would say the resource is there, but you are impeding my access to it, right? So there are midwives willing to perform this service, but you are prohibiting them from performing it by your regulation, right? And so you are interfering. And so I have a right for you to stop that interference. That's a right to be left alone by government, right? Alternatively, if you're in a situation where the service is not available, there's not anyone there to provide it, or there aren't the resources to provide it, then you have to pivot to a positive right argument. You have to say, I have a right for you to provide this service, to prioritize resources so that it is available. And I'm going to get into a more nuanced version of that in just a minute. So keep that in mind, because the respect, protect, fulfill framework, I think, goes even more in the direction that you're thinking of. Yeah. Okay. And here it is, respect, protect, fulfill. All right, so this is my pitch to say that studying law and policy, even just as simple as attending a talk like this, but maybe even, taking that study further, helps us identify the levers for social change. Understanding law and policy helps us identify specific actions and identify who has authority to take those actions, and to navigate a system for holding them accountable for doing so. So it helps us generate arguments, this RFP framework. Okay, so let's start with obligations to respect health-related rights. So this doesn't just include the right to health, but also rights to non-discrimination, rights to information, rights to water, food, anything of that nature. So obligations to respect correspond to those negative rights. Obligation to respect recognizes that those negative rights are important when it comes to health-related rights. So these are generally arguments that government should stay out of the way, should cease or refrain from an action that is negatively affecting realization of health justice. Most arguments relying on this, on rights protected in the US Constitution fit within this category. So you can now understand sort of like a right to abortion in the US context is really an argument, because we don't recognize a constitutional right to have resources committed to ensuring that abortion services are available. Instead, we recognize it as a right to not have the government criminalize abortion or unduly burdensomely regulate abortion. That has now been invalidated at the federal level, and state Supreme Courts are actively determining sort of what is the scope of their state constitutional right to abortion. It's also being voted on in referenda. And of course, this is also playing out in many other countries across the globe. So obligations to respect human rights might come across as something like government actors should refrain from promulgating misinformation about COVID treatments or vaccines. Government actors should refrain from criminalizing HIV transmission. Government actors should not unduly restrict, bar, or criminalize the sale or provision of safe and effective health-related services, drugs, devices, whatever. Obligations to protect get into more of this positive realm, but they are more cognizable within the US system, and they're sort of like in a gray area a little bit. So obligations to protect health-related rights generally take the form that you're saying the government shouldn't just stay out of it, right? That's respect. But there is some third party, right? Like a corporate entity or another person who's causing interpersonal violence, who I have a right to protection from. And that right to protection is a right that the government owes a duty with respect to. So this would include, this is basically an argument that the government should take affirmative steps, not just stay out of it, do something affirmative, but what they're doing affirmatively involves regulating or stopping someone else from doing something. So in the US legal system, these arguments generally take the form of calling on legislatures or administrative agencies to adopt protective regulations of third parties. So examples would be the legislature should pass legislation to more stringently regulate greenhouse gas emissions. That's an obligation to protect argument. You should regulate pollution, people who are emitting pollution, to protect us from the harm that they're causing. Another example, local and environmental health agencies should enforce existing laws, right? It doesn't just have to be adopting new regulations, but more actively enforcing and more equitably enforcing existing regulations against polluters, particularly in neighborhoods with high social vulnerability. Or, as I said earlier, an argument that the World Health Assembly should revise the international health regulations to ensure that private firms who obtain access to information or to viral samples have obligations to share the benefits generated by technological developments that rely on that sample or share information that was shared by communities and states in need. The last category, yeah, sure. Yeah, so obligations to protect would include things like campaign finance reform or transparency requirements and accountability for government officials or anti-corruption laws or things of that nature, right? Because the third party who you're saying the government should protect you from can include specific government officials as well. Is that what you had in mind? Yeah, so if the argument would be lobbying poses a threat because it's resulting in bad forms of regulation, one argument would just be the government has an obligation to protect the populace and to ignore the claims of these lobbyists. Another argument, though, that would be maybe even more sophisticated or nuanced would be to say the government has an obligation to adopt codes of conduct for officials or for legislators or for whoever else, right, is the target of this lobbying to ensure that they are transparent about who lobbies them and how, that they are subject to codes of conduct about acceptance of jobs after they leave an agency, for example, or acceptance of vacations, if you're a Supreme Court justice, for example, right, or a house for your mom. So those could also fit, right? These are then like categories that help you structure an argument. So if you're worried about lobbying, right, we just demonstrated that you can say, okay, lobbying is a problem and here's why. Who can do something about it? And how do you articulate why they should do something about it, right? You should protect population health by regulating lobbyists and the officials who they are lobbying in these following ways, right? So it's just so any given argument, you can kind of then use this framework to think about how to articulate what should happen. All right, so the last one is the one that's maybe most controversial and least cognizable within a US legal context, which is obligations to fulfill health-related rights. And this goes to the question earlier about what if the services just aren't available, not because of affirmative government interference, but for economic reasons. There just isn't the market, the private market isn't providing this service in the way that it should be provided. These are obligations, these are very firmly positive rights arguments that government should provide services, resources, supports, should take affirmative steps to ensure that services are available, right? So in the US legal system, it's not that these arguments are there, they're just not constitutional arguments. So in the US legal system, these arguments generally take the form of calling on legislatures to appropriate funding, to develop a taxation and spending program, or calling on agencies to administer the funding they have access to from the legislature in a way that ensures health-related services, resources, supports are available, accessible, acceptable, and of reasonably high quality. So examples might be arguing the legislature should appropriate funds directly to subsidize healthcare services that are lacking in availability or are insufficiently affordable. Arguments that the health agency that administers some kind of public healthcare program should increase the reimbursement rate for a particular service that is currently not sufficiently available or accessible. But also social supports might include services unrelated to healthcare, such as food, nutrition, housing, education, transportation, employment opportunities, childcare. You can apply this to any health-related service as well. And then I have this graphic that is too small to read, but I just want to say I have this whole thing that I work on about proving that law is a social determinant of health. And I'll just give you the top line idea of this. Is social determinants of health something you talk about a fair bit? I assume that anybody in these spaces hears a lot about social determinants of health. So here's my pitch. The idea of the social determinants of health has been to some extent co-opted by corporate healthcare entities who use it as kind of a euphemism for things that aren't within their control and that are reasons why they should not be held responsible for health outcomes, right? So social determinants of health becomes like a euphemism for it's not our fault that these outcomes are bad and we shouldn't be penalized in our pay for performance structure. But that's not the meaning. The meaning of social determinants of health really emerges out of scholars and then very much fostered by the World Health Organization that has a much more structural vision of what the social determinants of health entail. So I find it really helpful to divide this further into structural determinants of health and intermediary determinants of health. So in a kind of clinical setting, you might think of screening an individual patient for the social determinants of health. And there you're maybe asking about things like their housing situation, their immediate kind of social networks, their living and working conditions, whether they're working in a high risk setting, whether they have access to food, clean water, healthy air, exposure to carceral systems and institutions. Those are the intermediary determinants of health, and they matter. But as a legal scholar, as a policy scholar, as someone who's interested in health ethics, I want to go upstream to the structural determinants that affect those intermediary sort of determinants of health. And those include, and the comment about lobbying is appropriate here, things like the idea that interest groups and wealthy individuals exert economic power, the idea that discrimination, poverty disempower subordinated groups, the idea that there are media, religious organizations, and civil society institutions that exert cultural influence and define the terms of our policy debates, and that competing ideologies frame social problems and solutions in conflicting ways. So these all are determinants of health, and they are social determinants of health. Those are the factors that ultimately determine what our housing conditions are like, what our living and working conditions are like through political and governance processes. But my vision is that laws, policies, and spending programs are the connector between those structural determinants of health and the intermediary determinants of health. And I'll take it one step farther before I open up for final questions and say that part of my vision is that healthcare is a social determinant of health, that it shouldn't be healthcare and social determinants, that we should understand our healthcare system as socially determined and as in service of health outcomes, not as existing in its own right, for its own sake. And so I find this framework to be really useful, and I always find any opportunity to plug it to new audiences. So I will open it up and ask for any other questions about any other aspect of what I did before you break into your small groups and do an activity. And I can go back to other slides. I'll go back to my key takeaways maybe for now. Yes.
So a comment and then sort of an observation.
Yeah.
So I really like the available, accessible pieces because
Yeah.
when I worked at the World Bank and Human Development, Paul Hunt, who was a wonderful special rapporteur for health, was able to somehow craftily frame how health, human rights could help World Bank technical managers be better. And they really wanted to run out of the room and read human rights because it really is adaptable to Bolivia or Tanzania or Ghana. And I think it is a really good way to think about progressive realization. And Paul was great at that. I mean, he was a salesman with people, and really rigorous in his own way. So that's one part. The other part, though, is you have a lot of states parties that don't care. And so yesterday I was on a call about education in conflict. We were talking about Afghanistan. We were talking about the remaining Armenians in Nagorno-Karabakh. We were talking about the Sudanese. What can be leveraged out of health and human rights when the state's party, in fact, is the biggest denial?
Yeah, so I think this, I'm going to go back to this one for this. I think this gets really complex and challenging for all the obvious reasons, but then I think actually the main solution that people will give you is also problematic in ways that should be acknowledged. So the main solution that people will give you is to say, we need a vision of what some people call enlightened self-interest, right? We're never going to be able to convince anyone to do something for truly altruistic reasons. And so we've got to leverage their self-interest, their sense of what's going to keep them in office or what's going to make their buddies money or, whatever it might be, right? And so then you try to say, okay, but it's just a matter of showing them that if they're really smart, they'll see the big picture and they'll see how what we want them to do will ultimately further things they care about for their own purposes. And that can be very powerful as a tool. The problem is, I think we always have to be aware of the trade-offs that come with that framework. So if we're centering that self-interest of people in power, it's going to be more effective for some priorities than others, right? It's naturally going to push us towards certain resource allocations and certain prioritization. So I think an example that I've done a lot of work on is prioritization of emergency preparedness at the global scale, right? The idea that the World Health Assembly has really only done two main areas of health regulations, and one of them is emergency preparedness, and the other is infant formula, right? And so those are the two areas. And the reason that you get emergency preparedness is because you can convince wealthy countries and wealthy interests within impoverished countries, that they should care about this because it's going to affect them, right? The idea that, ooh, like scary infectious diseases that even like wealthy people can't protect themselves against are going to get everybody on board with building infrastructure for basic health needs. And so then you get this movement. This is kind of particularly after the SARS outbreak and sort of controversies over the failure to share samples and information from countries that knew they would not see benefits. You get this push to say we need to invest in like epidemiological investigation capacity. We need to invest in lab capacity on the ground level in each of these countries. Even if, and I think, we can see this with actual outbreaks, even if like that would not be the priority for many countries based on just sort of like a metric of disease burden or likely disease burden. So there can be, the answer is enlightened self-interest can be very powerful, but we should always be aware of the costs of using that approach. Is that responsive?
Well, I mean, it is in the sense that what I would call a mediocre government.
I think they're all pretty mediocre.
No, I think certainly I've seen in the area of health, for example, which you can make the argument about a healthy population, about disease, and all the rest. I think at the bottom end, like Zimbabwe or now say Mali, it's very difficult to make any argument for the government. And yet there's really good studies that Zimbabwe has the best health system outside of South Africa. And it was all self-destruct. It wasn't destroyed by war. It was just the late Mugabe.
Yeah.
I don't know what you do with it, but I think the other thing is like with Afghanistan. I'm not picking up your friend. I think that one of the challenges is you really want to get healthcare and education in the country, but you're also dealing with a government which has just taken CDAW and shredded.
Yeah. I mean, I think the other response would be at a certain point, you retreat to obligations to respect as your kind of firewall. And you say, we can't come to you and ask you, you're either too incompetent as a government or your government is actively, trying to harm often a subgroup within the population. And so instead we'll retreat to, at a minimum, stay out of it and let others provide these services. So it's something more like non-governmental mutual aid networks, and protecting them from government interference becomes, maybe the fallback position in a situation like that. Yeah. Any other, do we have time for a couple more maybe? Yeah.
Yeah, I have a question about how effective human rights and human health laws are. And similar to the last question, like how we have to advocate for certain populations and we're deciding for, we have to get certain populations to see how preservation of like certain communities help. But in terms of like human rights law, like international law in general is just really hard to enforce. But we see like internationally, like the 21st century, we've seen like the concentration camps of Uyghurs. And then we've seen like American atrocities for certain populations, like Abu Ghraib. Most recently, we see like Gaza, and so I'm wondering that like law actually has any impact, whereas like social push is made, but how important is it?
So I would say law has enormous impact, often in the wrong direction. So I would say the problem is not that law is not powerful. The problem is that law is determined by the distribution of economic power and political power, right? So, and that's an important distinction to keep in mind. In the kind of work that I do, a lot of the focus is then on, is it so thoroughly determined that there's no room to work around the margins? Is it so thoroughly determined that, you can never do the work of freedom with the master's tools, right? And I think the place where I land is that these are the tools that are available. They are, in fact, very powerful tools, sometimes revealing, pulling back the curtain on the interests that they're serving can be powerful. Sometimes convincing, triangulation, where you convince some other group, this is not in your interest to support what this regime is doing. Sometimes that can be powerful. But whatever you're trying to do, the tools that you have to do it are legal tools for the most part, and administrative and governance tools, right? And so even being able to articulate a vision of what the next step, what the future should look like in this space for this population requires a certain level of sophistication in using those tools, and is powerful, right? Because you can say a phrase or a slogan and people can say, what does that mean? What are you even picturing will happen if you get your way, right? So being able to articulate, here's how I would rebuild this with the tools that are available, which may or may not be realistic, but it's still a powerful thing to say, this is not something you can dismiss out of hand, that this is a pipe dream or an empty slogan or, you know, utterly unrealistic. You're then helping reveal that this alternative path is available and has been rejected, and you pull back the curtain on the reasons why it's been rejected. Is that responsive? It's not super optimistic or rosy, but like, it's like power is what is the answer. And sometimes that's pretty scary. Yeah, I don't think I have time for any more questions, but I've really enjoyed coming to talk with you. I'm sorry that I can't stay for the small group discussion. I have to go back up and teach another class back up the hill to the really stressed out students who are about to take their exams. But thank you all so much for hosting me, and enjoy your small group discussion and activity. Oh, I need to pull out my, just gonna take it. I think I already